I double checked that it was a
Yeah,
guest.
it made me put my name in, so I'm and it told me to be careful and quiet. So
Yeah,
I'm hoping
it's the right one. It's the right one. Yeah, but
yes.
it's definitely. But tell us more about this, because no one talks about this, and I do this drawing of the uterus and then the baby and the bag, and that there's a double layer in the uterus, and sometimes it's that tiny double layer. That, can you talk about this, please, from a midwife?
Well, it's not. I mean, we're not doing a research podcast, but
No, definitely not.
definitely not. So please see other people who do the research. I'm pretty sure it's Rachel Reed who talks about you have two layers of the membranes, or the waters. You have the amnion and the chorion, which are the other way around, I think. And basically, if the outer one breaks, you can have up to like a cup of fluid, which is a lot of fluid. And if you do there's a test like an amnisure test, which is looks like your pregnancy test in terms of you take a bit of the fluid, or often it will happen if a woman's like, I think my waters have gone, but I'm not sure. They'll be invited in for an assessment in the hospital, which means you having a listen to the baby on the CTG and doing a speculum examination, which is like when someone has a pap smear, and they'll sit and wait and see if there's any fluid pooling in the top part of the vagina. And if there is, they'll put one of these, like a swab in to get the fluid, and then to put it on this little test, which is similar to how a pregnancy test works. Like, it gives you a positive or a negative result.
Yeah,
you can get false positives.
Great, we love those.
Which is great. I think it's less likely, but there are some things that can impact it, like sex. So semen, I think, can show up differently. And obviously, if it's that layer between the membranes that's gone, you will have some amniotic fluid there.
Yeah.
So it will be positive and say that it is amniotic fluid, and you'll be treated like your waters have broken, which they have begun to release. But what that means is then you're on a pathway that usually includes a time limit, because ultimately there is an increased risk of infection if someone's waters have been released for a period of time, and the chance of having an infection would increase with the amount of time, right? Because it's a layer of protection that's been moved. Exactly how long and how great the increased chance of having an infection is a very long conversation. It's for another podcast.
But it would be so wildly variable, wouldn't it?
Yeah. But we know that one of the major factors in an infection is how many vaginal exams you have as well. So if someone thinks their waters have gone, obviously you don't want to put anything in the vagina, and you certainly wouldn't want to do loads of vaginal examinations. What seems to be a common process at the moment is that someone will say, hey, I think my waters have gone. There'll be an examination of some description, some kind of medical confirmation that, yes, that's happened. Now you have this amount of time before we're concerned. Do you want to have an induction right away, which some women will say yes to? Do you want to wait a day or 2 days, depending on the provider and what's happening, and then have an induction? So 70% of women will go into labour within 24 hours of their waters releasing. About 80, it increases, the chances of going into labour increase also, obviously, with each day. By about 3 days, most women, 90-something% of women, will have gone into labour.
Mm-hmm.
But if you haven't gone into labour at whatever time is the time that, is discussed with you, then you'll be offered an induction. And what happens with an induction is quite a lot of vaginal examinations. So, you could look down one pathway where someone waits a couple of days to go into labour, or you could look down another pathway where someone has an immediate induction, right? Say to reduce the risk of an infection of the waters remaining open for a few days. But that will then increase your chances of infection, because you're likely going to have multiple vaginal examinations, and every vaginal examination, adds your increased risk of infection. So it's a great little choose your own adventure of which risks you feel comfortable taking on, not feel comfortable taking on, what your provider's ideas are. Yeah. Is that it? And then Oh, and then the other thing just to confuse things is women can have a lot of vaginal discharge. Well, they do have typically a lot of vaginal discharge at the end of your pregnancy. Up to, I think, 80 mils is potentially like just what's called leukorrhea, so just vaginal discharge that's super normal. And if you've been sitting in bed, all night
Yeah.
or sitting down for a few hours, it just sits and pools in the top of your vagina, and then you stand up and you have a bit of a gush all over your undies, and you go, oh, I think my waters have gone. And obviously
Yeah.
it's close to term, so you're excited and you're waiting for your baby, and
That
then
starts
you
on
start,
the phase.
yeah, then you're like on this adventure pathway. Yeah.
Yeah, and it's so liquidy, that mucus. Like, it's not a sticky mucus, it's very liquidy. I would
Yeah.
say, like, I feel every second woman
Yeah.
calls me and says, is this my waters? You know, what really bothers me is that really quite often it's that second, like that little layer between the liquid between the two membranes. I feel like that happens fairly often, or maybe I'm just noticing it more for some reason, where the story then has become lately that the woman's water was broken because I don't know, right? So I don't do any of these assessments, but the woman then tells me her waters are broken. However, something came out and now nothing is really coming out. You know what I mean? Like, time goes on and nothing further, like the pad is not filling up, like, and I can then have my suspicions, but what I don't, it's not for me to say. But then the story then is that then later on, oh, your waters haven't broken, we're going to break them now because now 12 hours, 24 hours have gone by. And it's like, oh, well, it was never a thing. And that's actually what really gets me, is that how is this not more carefully evaluated? Because it is actually an enormous game changer. Because if a woman wakes up or in the middle of the night and there's that 80 mils or whatever that have come out, that's significant, or whatever. Or what? How much did you say that was inside
Yeah.
the membrane?
Yeah. Well,
Yeah.
like up to that.
Yeah,
I mean,
whatever.
that's enough to wet your undies and to be
It's
really
definitely, that feels
obvious.
different. Yeah. And then that's the story. Then they do the swab, and it's probably like 3 a.m. when they're going in for this little examination because everyone is excited. It tests yes. And then maybe they have some cramps, and then nothing happens for another 12 to 24 hours. And then her story is that her waters have broken and she now needs to get on with it. However, the baby is totally unaffected. The bag is still intact, or that inner bag. So I don't know. I feel like I'm knocking my head against the wall with this one because, firstly, who am I to say? The woman doesn't know, and it seems like the hospital doesn't really take this into careful consideration.
I mean, I don't even know. I couldn't tell you the numbers of the numbers of an increased chance of having an infection if one layer's gone, if two layers have gone, if it's what they call a hind leak,
Yeah.
which was very popular 10 years ago. Everyone had a hind leak, which is the idea is, instead of a big gush of water in front of the baby's head, up around the top part of the uterus, there's been like a break in the membranes there, so you'll have like a little bit of a trickle. Does that have the same chance of having infection as a big gush at the bottom where it's completely exposed? I mean, I don't know. I really genuinely don't know. So I'd love to know. I'd like to. I don't know. I don't even know if people have asked those questions or if there's been research into that, because I mean, that's like a whole different. How would you assess that kind of thing? So everything
And
does
there's
get lumped.
lifestyles, differentiations, and immune system differentiations on that one, I would guess.
And I guess I think what policies do when they work really well, is they're not individualized. There's just this sort of really general idea that, hey, this is something to be aware of. This is a pathway that can prevent a really crappy outcome for some people. And I was listening to Kirsten Small talk on someone's podcast. I don't want to say whose because I don't want to get it wrong. And she was talking about like the development of policy and how like there was this Wild West time when different clinicians had different protocols for different things, when Syntocinon was like we could put it at this rate or that rate. So, and then the idea of having some kind of uniform idea for safety, and so that everyone was on the same track, that makes sense to me. That feels like common sense, right?
Yeah.
But then it gets all the way over to the other side, I think, where we are at the moment, where it's, if it's written in policy, it feels like law, which it's actually not. A lot of them are actually not even called policies, they're called guidelines.
Yeah.
And the idea is to guide a practitioner who doesn't necessarily have the experience, or maybe they haven't read all the research on every single thing.
Yeah, fair.
But having been in a situation where I've written policies for hospitals, it's also interesting because then you read the previous policy, and then you read other major like obstetric and midwifery organizations policies and hospital policies, and then you go in and read the research that they've based their policies on, and it'll be someone else's policy, or and you end up down this crazy rabbit hole of like, oh, okay, but if there is a reputable organization, we make assumptions that they are basing their recommendations on latest evidence, which sometimes is true and sometimes is not true. Yeah. So I don't know. I guess
it's really good to hear, because for us people outside of that system, it really does feel like law. I mean, that's one thing that I say to every family that I support, is like, they're guidelines, they're not law. Like, you're not legally, you don't have to, just because someone comes in and says this policy doesn't mean you have to do it. It's a guideline. But it's really good to hear that it's not that set in stone, that it's like everyone is just like fumbling and trying to do their best, which is lovely. But I just think in so many cases, sorry, yeah.
No, sorry, I just wanted to add, if that's okay, like I could very easily go down a rabbit hole of slamming institutions and policies, because there are a lot of really crappy outcomes at the moment that are associated with institutionalized care, right? Which is the reason I don't work in one. But someone walking into a large institution with what we know is inadequate staffing at the moment, and a very junior staff mix at the moment, because since COVID, a lot of senior staff have left, and we've lost a lot of midwives and doctors, so a lot of junior staff are now in. I've been in that situation as a brand new midwife, and I didn't have the experience that I have now. So I was grateful to have something in order to maintain a level of safety.
Yeah.
So I guess I have that in my mind. It's like, it's not, I think it's very complex, and I don't think that institutions could possibly run. The word of efficiency is a shitty word, but it is an appropriate word when you're talking about an institutionalized way of doing something.
Yeah.
Because there is only so many staff members and there's only so many hours in the day.
Yeah.
So I get why. I can understand why it's developed the way it's developed. Is that the best thing for women having babies? No. Like, I don't think so. Individualized care is the care that is the gold standard, and it actually has 100%. Better outcomes. Yeah. But if you're birthing in an institution, you don't want to walk in. I wouldn't want to walk into a place and be like, well, this random person I've never met before can just do whatever they want. I'd be like, oh, why are you doing that?
But few people ask. But I guess that really brings us to the point of, yes, so we understand why the institutions are there, why they're run like they are. We can't really blame them for that. We would probably have done the same thing if we came up with that system. But what it does bring us to is the women, the couples, the birthing people walking in there have to be the ones who ask the question, who demands the conversations to be opened, and demands the individualized care from the providers in there. And so I think that's where the focus lies. Not the blame game, but just like, you can't walk in there with no information or no support. Well, you can, but then you end up on a guideline pathway. And that's okay if that doesn't, if that's what you want, that's great. But there's just, you can individualize it, but you kind of have to demand it. That's how I see it. You have to ask for that. You have to demand that they slow down, think outside the box, and have intelligent and reasonable conversations. And in my actual experience, that's totally doable a lot
Yep.
of the time. You just have to know how to start those conversations. You have to have some, back end information first. Because like you say, you never know who you're ending up talking with. Are you talking to someone really senior who's done a lot of different varied births, or are you talking to someone brand new who's like, I just read the guidelines and maybe I'm a little bit personally nervous too. You don't know who you're sitting with. So you have to come in with some information. So, but yeah, that one thing with the breaking of the waters and the layer of the amniotic sac, it's really tickling my brain. It's irritating me greatly that there isn't more conversation, that there isn't nuanced conversation when a woman says, I think my waters are broken. It's just very black and white to me. I can't understand it.
I mean,
Because it's
I
not black and
understand
white.
it. I understand why it is. I just, because of all the reasons, and and there isn't time, and they're probably, like, I would say most I don't know if that's a really huge number of clinicians, of midwives, doctors, yeah, I could say most even that I've worked with in institutions, if they're stopped and asked questions, they'll answer them openly and honestly, and like be really willing to engage in a conversation.
Yeah.
But I think if someone's planning to birth in a setting like that, you have the option of going with the flow, which I've heard a lot of, and we all know when you go with the flow, you just go with, you have to know what the flow is, right? And if you're actually fine with whatever comes, then maybe that's the right thing for you. If you just feel like, I can't think about it, it's too stressful for me to make any of these decisions, that's a lot of pressure, I don't want to be responsible for anything, just somebody else decide, then just look at what the rates are of, cesareans and interventions and breastfeeding and depression and all those things, and be like, okay, well, they're kind of my odds.
Yeah.
But if you want something different, or you want to have a voice, just, I mean, like you're saying, it's not, I hope it's not that hard. I hope I haven't just been surrounded by great people. I would hope that women could say, just ask, and then there would be a conversation, and I mean,
there's not. I'm sorry to say.
No, I mean,
so sorry.
No, you're fine. Okay, so as a doula, because I think we both have this experience. We've talked about it where I speak to people and I'll hear about their previous birth experiences, or I'll be at a party and someone will tell me their birth story, or literally anywhere I go, and then we get stopped and get told like the whole story of everything that happened in their birth, and my brain can't help but try to make sense of it, right? Because sometimes there'll be stories and I'm thinking, oh, that's interesting. Like, that part is incongruent with what I see as part of that story usually. And sometimes I'm curious and I'll pick it apart, and sometimes I just listen.
Yeah.
Depending on what mood I'm in and where I am. But I will say that it's impossible for me to really understand what happened in those situations, right?
Yeah.
Unless the woman herself has she has a clear story, but often she'll be like, oh, I'm not sure, and I don't know, and I'm not sure what that was done, and someone did something to me, and there's a lot of vagueness for their story. So that tells me straight up that she hasn't probably had really great, like, informed conversations, probably.
Yeah.
Okay, so as a doula, though, when you have someone coming to you with a story, or here's what my midwife, doctor, hospital says I should do, and it sounds to you a little unusual, or you start having those questions pop up, how do you help them to have those conversations? Because you're not even there for that conversation.
No, I'm not there for the conversation. Well, first I ask them what they feel about it, and following that, I ask, what is your intuition? Because my role is to bring the power back into the woman. Because we all know that, we can have ideas and experiences and knowledge, but if the woman is not on board, it's going to be a dead end in terms of her experience. So that's always the first place I go to. And from that, those two questions, then there's always alarm bells that comes up. So she will then probably flag something in that experience. So, but I don't understand that. But the doctor said, and then, but how does that make sense? So that's what I then go on, because I don't want to necessarily start seeding fears in a woman or anything negative. So I just try to actually follow her lead on it. That's usually enough, because women are very intelligent. Couples are very intuitive, I find, in that time when they're about to have a baby. And so I will just help her ask those questions more deeply. And then if it's a question where I know I have research I can send her, often I try my best to send research on both sides of the fence, if there is a fence, and there's always a fence. But I try to do that so she can read both or understand both, and then maybe from that sparks a conversation that she can have with her midwife or doctor. But very often she actually comes to her own conclusion. So she wants to proceed, or she doesn't want to proceed, or she wants to give herself some more time. And I help her navigate that from within herself. There are times, though, in all honesty, where I like when I have those alarm bells where, for example, with the waters breaking, where a woman is not really having any contractions. Maybe it's on night 2 after the waters broke. And I asked her, like, is your waters, and they've been diagnosed as waters are broken or whatever with a swab, yet her pad is not filling up. She's not really having any signs of labor. That's when I might say, well, here, remember we talked about the membranes, and there can be that little space in between the membranes, but the actual membrane around your baby could potentially still be intact. And maybe that makes a difference in terms of how your labor is going to progress. And so I try sometimes to just, I guess, talk about the physiology again, see if we can make sense of what's happening, and then whatever happens for the woman, because it's always about her comfort zone. Always. So if then a woman, for in that case, if that makes sense to her and she's like, oh, right, well, then I feel like I have a lot more time if the membrane hasn't, well, okay, well, that's a different conversation to have with your midwife or doctor. Or if she's really uncomfortable and she just want to go in and break those membranes fully and then hopefully go into labor, then that's what she should do. So I guess I just really try and bring it back into encouraging the woman to find her own questions. I don't necessarily want to give her more questions.
I think that is great. That's great. Yeah, it's really good, because I think you're right. I think there's a lot of when you're walking into that environment, I would say most people need space after those conversations to have a think and then come back.
Always.
Yeah, because in that
Such a good
environment,
point.
everything feels really, really intense and urgent, and sometimes it is, and a lot of the time it's not. But yeah, I think it's when you're seeing this thing happen in front of you, but there is this part inside of you that's like, oh, like someone said that there's a concern with my baby, so they've suggested for me to have an induction, but that will happen next week. So that is such a sometimes that's appropriate. I'm not saying it's not. Okay, this is a made up clinical scenario, but the questions are like, how urgent? How should I be very worried about my baby? Should I go home and just be stressed for the entire week?
Yeah, exactly.
Which is definitely what a lot of people do. Because
100%.
Yeah, because now you've told me something's wrong with my baby, right? They're the magic words to get any woman to do anything.
100%.
So, but like, go home.
Go home and think about that. And two things I want to on that is, one thing is, I think when you sit, because I've been that woman. I've been that woman who were told I had to have an induction, otherwise bad things could happen. And there was like a list.
Sorry, it's not funny though. Here's a list of horrible things that might happen.
So now, either do as I say or go home and stress about it, or maybe just stress about it in general. Anyways, so I've been that woman where you sit, and that was, in this case, it was with my first baby. So I wasn't a doula yet. I was very clueless. And when you sit in front of a medical provider, you are a different person. You're not, your brain has changed a little bit, and you're just in receiving mode. You're not in dialogue, we're equal mode. It's not happening. It's very few people that can feel that way, I think, in front of a medical provider. So that you go in and you have maybe a 10-minute, maybe half an hour if you're lucky, maybe an hour if it's like really extremely lucky, to have this conversation or monologue at you. And then, as you say, that space after is crucial. And that's often when I speak to women. But that's where all the things trickle in, and you need to sleep on it, you need to eat on it, you need to think on it, you need to talk to someone about it. But very often you kind of like, that conversation leads to a booking of an induction or something that has happened from that short conversation, where you kind of just goes, well, if that's what's best for my baby, then like, what can I say? Yet so much happens after, and it's very hard once you've been booked into the system or something has been diagnosed from that conversation to undo and unravel that. So that's one thing where I always say, unless it's a true emergency, you have time before you sign on the dotted line, before you agree to anything. Give yourself some space to consider and maybe ask for advice or read some more, whatever. That's one thing. But going back to when you asked me, what do I do when I speak to someone about this, I think my objective is never like, what's the right or wrong right now, but what I always try and visualize is, how is she going to feel at the end? Because I am there at the end. I'm there for months and months after birth, right? The doctor isn't, or the midwife isn't for that long. And so I always think like, okay, what decision making is she doing now? And how is she going to be in the postpartum? Is this going to be the pathway for depression or anxiety? Is this going to be the pathway for her to feel like she failed? That's actually where I'm sitting. That's where I operate from. So that I try and do it in a reverse way, where I go, okay, ask these questions. What are the answers that comes from that? Because then I know that she's asked enough questions and she's taken enough steps that she won't blame herself, hopefully, at the end. And that's actually where I sit the whole time, because I do feel like that is part of my responsibility, is to kind of keep her as a whole in my consciousness. And like, so I know her by now, I know her needs and wishes, I know her worldview, perhaps her religion, anything that really is relevant for this family and for this woman. And so I need to hold that whole space so that I know that when she has her baby in her arms and life has begun in parenthood, that we've operated from a place of wholeness in that. That actually is where I come from. And I will say that to her. It's like, if you make this, like, if you do say yes to this induction, or if you say yes to rupturing the membranes, do you feel like you're saying yes to a place where you will agree with yourself after birth? And that's hard, it's complex, but that's really important, because often there is no one else there afterwards, and she might really regret it or something. So she needs to have done these decisions from a place where she feels like she did it wholeheartedly, and from a really complex but whole decision-making place.
And that just feels so protective, because we certainly can't predict what will happen exactly. There are definitely enough like decision points where you're like, well, now, there's a higher chance of this happening and a higher chance of this happening, or typically it might look like this,
Yes.
in the next few days and weeks. That information can be really powerful.
Yeah.
Not even to dissuade people from, and sometimes there's no choice, but sometimes the pathway is very, very clear.
Yeah.
But just having an awareness that something might not then look how the dream has looked, is really great preparation. I think a typical example of this is if someone's having a cesarean section for whatever reason. Like, I try very hard to always have a conversation with women about, if it's their first baby, how there's a higher chance of delayed lactogenesis too. There's a higher chance of their milk coming in a little bit later. It will come, but instead of coming in day, 3 or 4, it might come in day 5 or so. And what that means is, and pulling that apart, and that can mean a baby that may potentially lose a little bit more weight than another baby, maybe a higher chance of having some jaundice. Here are the ways we can try to mitigate and minimize some of these risks. And for some women, it will be, lots of pumping, and for some women, it'll be really trying to make sure the baby's with them as much as possible. Sometimes babies go to the nursery. That also increases the chance of the milk coming in a little bit later. And we know that, if someone's having an emergency cesarean and their baby's going to the nursery, then we've got a few other reasons why there's been some signals lost in their body, to get that process going. But reassurance that it actually, even though it's not normal, it's not the physiological act, we understand why. We know that what's most likely causing this to occur, and so we can be prepared for when that happens, as opposed to having no preparation that might happen, getting to day 4 or 5, your baby's lost X amount of weight, now it's under lights because it's got jaundice, and you feel as though you've failed because you can't breastfeed, and then you might as well just give it all these bottles, which may be the right thing. But if your plan has been to breastfeed from the start, we haven't supported you to do that. We've not given you the knowledge to understand that this is within this medical pathway, this is quite common. And here are the things that we can do to work through that. And sometimes that might mean having a bit of formula as medicine for a day. And sometimes it might be getting some donor breast milk, and sometimes it might be expressing, and she can then make the choices that feel right for her, in that new pathway that's kind of opened up.
Exactly. It's exactly that. It's that she needs, those steps has to be clarified so that she can, otherwise it's not a complete decision. If you haven't been told, yes, so you have these, whatever, 2 or 3 decisions that you can, pathways you can take. And here are the consequences, pros and cons of each of them. This is what will unfold, maybe or likely. How do you feel about that? And how can we prepare for it? Very different feeling than why didn't anyone tell me? And those are the stories we hear, right? At, in aisle 7 at Woolies, right? These are the stories that we hear where no one told me that this was going to happen. And that's where a lot of trauma sits in that, why wasn't I fully informed? Why didn't someone take the time to tell me what I could do? Because women are so willing to do a lot for their babies and for their own outcomes. And they just want the information. Most of them are really on board with the fact that we can't control it. We can't say this is 100% what's going to happen. I haven't had anyone complain about that, but they complain if they don't have the information.
I think on that track as well, when you talk about the women who stop you in, the supermarket, and they start telling you what happened, the one that gets me the most, that drives me probably the most crazy, is when someone tells me, oh, I couldn't breastfeed, because just thinking on that part, oh, I couldn't breastfeed. And I'll go, oh, wow, that's really, usually it's in the context of they're disappointed about it. So I'm like, okay, I'm really sorry that happened for you. And then they'll tell me the story behind why they couldn't breastfeed. And I don't say something usually, unless someone's really asking me. I'm like, I'm trying to do my groceries and get home to my kids. But, if it starts to ring so many alarm bells and so many questions, and I'm basically hearing this really common pathway, about, from, induction to cesarean to baby being separated to delayed milk production, and then the baby lost too much weight, and then jaundice, and if I hear that really typical pathway, which I do, it always causes me to pause for a minute, because I think, now this woman's got a story that she can't breastfeed, right?
Yes.
Which is potentially bullshit. What I say, one of the biggest reasons women stop breastfeeding is a perceived low supply. So not that they have not enough milk, but that they believe they don't have milk, which may or may not be, but most of the times is not the issue, and most of the times is manageable, and there are, all the things. But God, it makes me bite my tongue.
Yeah.
Because there is that really frustrated part of me that wants to be like, all right, now, here's what we can do. Here's how we can prevent that. And that kind of, for the woman as well, to not feel like she has that in her body, that sense of incapable or not capable to do something, which is not a nice feeling to carry around in your body. But also, you and I know that then becomes the conversation that she has with other women. And
Yes.
so that's why when women book in for care with me and I ask every woman, do you plan to breastfeed? And they all say yes, if I can.
Yeah.
And it
Everyone.
literally those words verbatim for like 99% of women.
100% of the time.
Yeah. Unless I've had a baby already, and then it's like,
Yeah.
probably. If I probably can. Like, it's just this overwhelming sense in our society that feeding your baby is going to be really problematic, you
Yeah.
know. Anyway, that is the conversation that stops me, because I think, oh, I can see what, and again, I wasn't there. I don't fucking know. I was not involved in her care remotely. I could be completely off track.
Mm.
But the odds are most of the time that's what's happened, is that there's been somewhere in the care that she potentially could have been supported a little bit better.
Yeah. And also understanding that the cascade effect
Yeah.
is what caused the potential,
Yeah.
like not her.
Yeah.
She didn't do anything wrong. It was the
Yes.
cascade. It was the journey that made it a really bumpy ride. And then you need a lot of extra support for that breast milk, for example, to take
Yeah.
hold.
Or even in the case where, for whatever reason, the outcome was that she chose not to keep breastfeeding, or she didn't continue breastfeeding, and she felt great with that new decision, then that's great too. At least it's coming from exactly what you're saying, coming from a place of power, coming from a place of informed decision making. The women that I've cared for who have had what I think could be seen as, highly traumatic births, which, just, I'm not using any trauma definition, but let's say the births which are completely outcomes that are totally outside of what they wanted, in the whole spectrum, and very disappointing, and the emotional element is quite high. I find the women who I speak to weeks afterwards who, I won't say are okay, but there seems to be the less ongoing stress and emotional sadness and grief around, are the ones who feel like that they've been involved in the decision making. So the
Right.
outcomes aren't necessarily different, but how they're treated and how they're spoken to, how they're listened to, and the questions that they ask. And the women will, I will get very fortunate to have women come to me who have maybe not had the ideal birth the first time and want to do it differently. And sometimes, I say most of the time, actually it works out well, and sometimes it doesn't. They don't have the birth that they hope for the second time. But the thing that gets me the most is when they talk about how proud they are to ask the questions. It's not even about me listening to them or doing anything. It's really never about me, but it's about them, and them taking back that space of asking questions and demanding information and slowing down that pathway to suit them. And sometimes they'll end up in exactly the same place, but they'll feel just so good about it in terms of who they are,
Yeah. Because they were part of the journey. They were not just being dragged along and just what's happening to me? I mean, gosh, I've seen that so many times too, where you go, wow, that wasn't the birth that you had planned for, but the woman would be so proud of her outcome because she was the captain of the ship.
Yeah. I wish that for every woman having her first baby, that
Yeah.
she'll be able to feel, and it's hard when you've not done it before, and there's uncertainty and fear and all the other things that we know go around, but how great it would be, to be in that space of oh no, I've got an extra question, please, or I'm going to take 5 more minutes, or just that. I think that would be quite impactful. Unfortunately, the power dynamic, like you're saying, is so different in institutions and how most women are birthing, that it's a bit of an uphill battle, I think. But
It is,
but doable.
of course. The thing
Yeah.
is, I think maybe if we had a goal for this conversation, or if we had a wish for this conversation, I can feel that what I'm hoping is that if women listening to this, that this opens up inside of them the notion that they 100% need to be in charge of their own body, and they 100% have the right to ask for respectful and intelligent conversations about their options, their care, their how they want to be treated, etc. Because, like we said earlier, the system isn't going to change. There is a system set up. It's going to take a long time for the smallest of changes to unfold. So let's not put the pin in that area. We need to actually really evoke this in the individual to say, hang on a minute, I have the power. I have the autonomy. I can have these conversations. I can slow down this conversation and say, I hear what you've said. I'll get back to you tomorrow, and we can resume this conversation when I've had some time to rest and read or whatever else. Because it's very rare that when women do this, because I actually spend a lot of time talking about this concept with couples, because it's really hard actually to be a doula when you've made the plans, you've had the connection, and they have their wish for their birth and blah blah blah, and they get sidetracked like that. Because I think when I started out as a doula, I didn't spend a lot of time talking about their rights or whatever, or like how do we have conversations in the system, how do we all these different things. So that's and I guess something I implemented later on. But when I get the call, like, oh, we're driving in for an induction now, and I don't have the whole context, for example, that happened a few times in the beginning of my doula journey. And I'd be like, oh God, like, oh, there's so many things we missed here. And now the ship has sailed. When couples and women understand that, no, it all lies within me. No one can do anything to your body or your baby without your consent. That changes the conversation immediately. So I'm just hoping that this can be the jam session that really evokes that in anyone listening, that please take back that autonomy. Please take the time to definitely educate yourself. But you are in your absolute right to ask more questions. Just say, I don't understand. I don't understand what you're saying. Because sometimes the lingo is really dry, and you can tell someone has been saying it in this one way for at least 15 years, and they don't have another way to explain themselves, and it's not going to translate to most people. But we just accept it. We're like, okay, gosh, that sounds intimidating. Okay, but we need to change that. You need to actually show up and demand a different quality of conversation. And then I do see, when women do this was my point, that when women do show up like this, and they have a different mindset, and they're taking that power and that autonomy, then most doctors and midwives are like, oh, this is great, you're interested, let's talk about it, because they're great people. Most people are really wanting to do the right thing. So you can really evoke that in people, but it requires you to show up as that spark of curiosity, and then you can really change the energy of the conversation. Every now and then, I will say that women and couples are met with a lot of like, no, I will not allow you to question me. You do have to take my word for what I'm saying, and could potentially be offended. But if that happens, yeah, maybe you're in the wrong care.
I mean, it's good to find out beforehand, actually, isn't it?
Yeah. Really. I do have like, these are some questions you should ask before you're in your second trimester, and here are the questions that you need to start taking on later. Anyway, so I really hope that this conversation I think most of our conversations actually do evolve around that, but that regardless of how your birth is starting to unfold, unless it's a true emergency, which is really, really rare, let's face it, you can really demand time. You can, demand a different quality of conversation.
I agree, and I agree with you that is definitely the strongest wish and hope that I would have for this conversation, if anyone's listening. What it's invoking in me is a couple of things. One, I really love like women who demand and who push back. Like, it's a personal favorite of mine. But like we said, we have statistics that show us that a lot of women don't do that in that birthing environment, right? Because we meet them, they say, I really would like to have this kind of birth, and then we've got more than a third of women having a cesarean section, right? But there's not a third of women who are wanting it, right? For all the different reasons. So if you're one of the women who are listening to this and you feel like that is actually too much to ask for me, like that feels really intense to demand, to push, then I would ask, try to turn on your curiosity. Just like what you were saying, I don't understand. It's really important that you just spend a bit of time listening. Maybe it's after the appointment, just sitting in your car or talking with your partner or whenever it is, just sitting like, well, how do I feel right now? Right now, how do I feel? Do I have more questions? Because usually there's 10 more questions when you walk out the door. Write them all down. You can rearrange your appointment schedule. You can have an earlier appointment or you wait to the next appointment. You can always speak to another person. That is always your right. But also, maybe that's the time when those questions come up. Maybe it is hard for you to hold your space, especially if you've never done this before. But what a great thing to learn, because you're about to be a mother and that's your life now. It's demanding for you, demanding for your baby. But if you can't demand, just you can be curious. And it's actually not your job to have to be educated about all these things. It certainly would help you to have some information, but you may or may not have time or accessibility for that. But the person, whoever's caring for you, it's their job to provide you enough information so that you feel really secure and informed. So if there's a question, if there's a doubt, then you can gently and kindly say, hey, I don't understand. Can you please explain again? Can I have some more time? If that feels more achievable for you, then that's okay too. You don't have to do it in like such an intense way. You can do it in your way. And the other thing I was thinking when we talk, you and I both know that doulas get a bad rep for being disruptive, and this is why, because not because doulas are disruptive, but because this is disruptive, because asking questions is disruptive, because taking time in a place where there's not a lot of excess time is disruptive. And that could be the discomfort that you're feeling as a woman, is that you're feeling the discomfort of being disruptive, even though you're not trying to be disruptive, which does that make any sense? Like, because the very nature of you asking a question, slowing things down, it can sometimes cause a bit of a friction. And maybe no one says it, but we're highly perceptive. And certainly when you're pregnant or in labor, your senses become so much stronger. You don't need many words to really read the room. So be aware of that as well. So when you're feeling that, like, oh my God, maybe I said the wrong thing or I shouldn't have said it. No, it's fine. You've said everything fine. It's just that you've now taken up space. And that's just how it feels, because then no one's used to that. So yeah.
That's a really great point, which feeds into many other areas outside of pregnancy as well, in terms of being a woman in the world. So just saying, but and I think to all of that, you're probably not, when you have questions, or if you question anyone, or and you ask for the questions, you're not going to be met with a loving smile and like, oh, I'm so glad you asked. I should probably have added that it's probably silence, or like maybe it might be a right. So here are the guidelines again. Like it can be a very, very dry conversation sometimes. But so that's a great point, that it's not always a soft landing, asking for more space, more time, more answers. But it's always going to be a win, I suspect, in the long run. Yeah, it's a great point.
And I love that you think and articulate that it's not about this moment, because I think in obstetrics it really is about getting the baby out, or babies out. When I had my twins, I think it was the next day, my doctor obstetrician, she came in to just to check in on me because I'd had a complicated birth. And my husband went to ask her a question about one of my babies, and she went, oh no, they're out. She was like, that's not my job. And I loved it. I mean, she's a beautiful doctor. We had a great time together having my babies, but I loved that she was just so clear that her job, no, we don't. The babies are out now. That's a pediatrician. And as a midwife, we hang around a bit longer. I hang around for 6 weeks or so. And you're there for months and months down the line. And that I think that probably does give us a unique perspective and a different way of looking at this. What we know is not just a mechanical experience, is a really transformational experience.
Yeah.
And has the potential to be just so incredible. Yeah. But we'll definitely be impacting you 12 months from now.
Oh, yeah, for the rest of your life. And so I think, assumptions can be dangerous. I think that's just a good reminder that it's really dangerous to assume that any care provider is considering your whole life in a holistic way. That's a dangerous assumption, because that's a great example. Baby's out, the obstetrician is off.
It was there for me, but not babies. Yeah.
And that's, but the obstetrician is there for like this much for you afterwards, but that's their job. So it's stupid to make other assumptions. It's very clear what their job is. So that's where, that's where we have to take that power back. But maybe that's a good place to end it. With that, I have a client in 4 minutes.
Oh, perfect. Go do your job. I'll see you next week.